So what I thought we'd do today is do a little review here of some of the other past neonatal stuff that I've done. So, and I'm going to try to do it as a Jeopardy game. I had problems earlier. That was, again, one of the things not making me smile today. So I'm hoping that you guys can see it. Can you guys, is it moving properly? Are you guys seeing it on the screen there?
Right now we're seeing the presenter's view sort of thing, I think.
Oh, are you? Okay.
We're not just seeing the main slide, we're seeing the ones coming up next too.
Okay, let's try that again. All right, hang on. Let me stop share and I'll try again. I'll put this up there. That's been my life these days. Technology is telling me it's time to retire. All right, are you guys seeing that now? Does that look like the regular screen?
I mean, it's fine. It's just the same screen.
Oh, you're kidding, hey? Huh.
But maybe that's how we're supposed to be seeing it. Are you hoping that it's just one
Yeah.
thing? I think we can make it work.
But it's the Jeopardy game, so it's not really very helpful if you guys see the next.
If we see the answers, no.
No. And so you guys are seeing like the presenter view, hey? Let me try this one. Okay, let me try that one. Is that one the same?
That's perfect.
That's actually working? Wow. That'll make me smile today. Excellent. All right. So just to say that I'm calling from the traditional territory of the Ktunaxa, the Syilx, Okanagan, and Sinixt nations, also known colonial as out in Balfour, that's Kootenay Lake. That's me with my canoe out in Kootenay Lake. So I'd like to say that the Ktunaxa, the Syilx, and Sinixt nations have obstetrical knowledge and skills that have enabled their communities to thrive for generations. So it is my hope that as we move forward with reconciliation, that the obstetrical knowledge and practices of the Indigenous people that we live and work with will be supported in the acute care settings. So please take a moment to consider on whose lands you are situated and how you might support the calls to action from the TRC in your practice. Okay, so what I thought we would do is I just gonna take it's like a little mini snapshots of the past neonatal stuff that we've done. So looking at the new Safer Sleep document, has anyone seen the new Perinatal Services BC Safer Sleep clinical decision support tool? Like it's kind of like, there's like stuff we can give for families. Has anyone seen that? Am I seeing nods, thumbs up, maybe? Okay, if you haven't, do take a look. Just Google Perinatal Services BC Safer Sleep, and we're going to talk a little bit about it, but it's actually a new sort of updated, just to sort of appreciate it's more nuanced than how we used to talk about safe sleep for babies. Taking a look briefly at some alternative feeding methods, so looking at specifically the late preterm, a quick review of some respiratory distress in the newborn, looking at our provincial transport processes and documents, and then trauma-informed practice, culturally safe practice when caring for an unwell neonate. Does that sound okay for everybody today? Yeah, okay. All right, dumping straight in, and I'm hoping you're seeing my Jeopardy. Who would like to start with a number, or should I pick somebody, or does somebody just want to jump out there and try something?
I'll take transport for 10.
All right. Okay. So by dialing 1-866-233-2337, rural sites will connect with the BC Emergency Health System PTN, Patient Transport Network, who will connect you with the rural MD, RN, or RM. So any of us can call, but they'll connect you with this person. So who are we reaching when we call? When we call transport, who are we actually going to be connecting with when we call for an unwell neonate?
Well, hopefully a neonatologist at a high care center.
Yeah, so you're actually going to be talking to the BC Women's Perinatal Transfer Physician. So it's very specifically focused on a BC Women's. Yes, and they'll be able to sort of prior tries and figure out what we're going to be doing for that babe. Excellent. All right. Who'd like to pick another one? Jennifer, do you want to go again? You're on a roll.
Okay, let's do alternate feeding methods for 10.
Okay. So there's 8 types of alternative feeding methods or lactation aids that are applicable for the late preterm. Anybody have any ideas what all of those things might look like or be?
Well, breastfeeding is not alternative. So I'm going to say finger syringe,
Yep.
SNS,
Yep.
gavage,
Okay.
spoon, cup, bottle,
Okay.
dripping it into the side of the baby's cheek,
Okay.
hand removal, like finger removal from the breast and dabbing it into the baby's mouth.
Excellent.
I can't think of any others. What's that, 6?
Andrea, can you think of anything that Jennifer might have missed? How about you, Judy?
Did you mention spoon feeding? I didn't know.
Yeah, yeah.
Oh, okay then.
Yes. So the only one that you didn't mention was the breast shield.
There you go.
Yeah.
A breast pump counts as an alternate feeding method?
Well, it's a lactation aid. Yeah.
Oh, okay. Okay. I was thinking of what gets milk into the baby versus what gets milk out of the mother.
Yeah, kind of. Yeah, totally. But you definitely covered it all. That's fantastic.
That's 7.
That was
You asked
7?
for 8.
1,
Yeah.
2, 3, 4, 5. Oh yeah, you're right. Wow, I can't count apparently. Let's include, yeah. So the other one we could have was the which one did you guys say?
You
The
said spoon.
spoon, yes. Spoon. Thank you.
Is gavage
Bonus.
on there,
And
Andrea?
gavage, yeah, there's lots in there. So those are just a few of them. And it could just be when I cut and paste that I didn't quite get them all. So I did a little cut and paste yesterday. So thanks. Okay, Andrea, do you want to pick one? Just because I see you right there on the bottom of my screen.
Safe sleep for 10.
Sleep for 10. All right. So part of the new safe sleep is this triple risk model. Has anyone heard of it? Like the different components of the triple risk model. Okay, and they make sense when you take a look at them. And really, the triple risk model is acknowledging that the sudden unexpected infant death during sleep is sort of an intersection of 3 overlapping factors. So it's not quite as straightforward as in, you should sleep on, no bed sharing, end of story. It's more nuanced than that. So we'll take a look with another question about what those 3 overlapping factors are. So thanks for that, Andrea. Judy, do you want to pick one?
Sorry, I'm a mouthful of just having my lunch. Pass for now.
Do you want to pick one?
Okay. How about respiratory distress then?
10. Okay, you bet. Okay, so how much fluid is in the fetal lungs in utero? Any guesses? So this is prior to birth, prior to sort of the processes of labor that start moving that fluid out in preparation. How many mils do you think are in there?
Pat.
Yeah? Anyone else has a guess? It's more than you realize. It was more than I realized. You guys ready? We'll just go for it. So it's 30 mils per kilogram. So if you have a 3 kilogram baby, that's 90 mils of fluid that need to move out. So it's not an insignificant amount of fluid. Yeah. Great question there, Judy. All right, Rebecca, why don't you pick one?
I will have to go for safe sleep because I'm a mom, so I know a little bit about this. 20, please.
All right. Well, these are the 3 factors in the triple risk model. What do you guys think? What would be the 3 factors now that they've considered to be all sort of contributing to the potential for having a sudden unexpected death in infancy?
I'll try one. Prematurity.
Yeah, absolutely. Excellent. Anyone else? Can you think of one?
Is temperature one of them?
Yeah, so that would be like exogenous factors, like what's the temperature of the room? Excellent. And can anyone else think of the other one? I'll pop this up there. So we know that exactly what Rebecca was talking about, pre-existing vulnerability. So was this a premature baby? Was this a male baby? They were more at risk. Does this baby have any sort of upper respiratory issues, any congenital issues? Critical development period. Does anybody know when babies are most at risk of having, and we're going to talk about that a bit more, but just thinking about that, when are they most at risk for having this sudden unexpected death in infancy? And the exogenous stressors, so exactly like Jennifer saying, things like temperature, and we'll take a look at some of the other factors as well. Great. All right, let's go pick one more. Andrea, do you want to pick one?
Sure. We'll do respiratory distress for 20.
Okay. So what is the gestational age that surfactant production dramatically increases? Any guesses?
34 weeks.
Yeah, 34 to 36 weeks. Excellent. And that we know those babies born prior to may need some extra exogenous surfactant. Excellent. Do you want to pick another one, Andrea?
Sure. How about respiratory for 30?
Oh yeah, we're rolling on this. Whoops. Oh, it does that if I don't quite hit it. There we go. Okay, so respiratory distress syndrome, also used to be known as the hyaline membrane disease, involves the deficiency of this chemical compound. What might that be? We were just talking about it.
Is it surfactant?
Yeah, absolutely. Surfactant. So that's what RDS is from. It's from these babies not having enough surfactant, either because of their gestational age or because of other things like meconium, which has destroyed meconium aspiration. The meconium's actually destabilized the surfactant. And so now that they will actually present with RDS. Excellent. Okay, let's go with another one. Jennifer, do you want to pick one? Oh, we can't quite hear you, Jennifer.
Sorry, alternative feeding methods for 20.
Okay. All right. True or false? Cup feeding is the preferred choice as an alternative oral feeding method.
That's true.
Yes. And cup feeding, there's some incredible videos. They are so cute when they're cup feeding. The only thing I have found is that they have to be really quite alert. I don't know if there's any way to get them to feed when they're not alert. I don't know what you guys' experience has been. But that's certainly been what I've seen. Andrea, I'm just curious, in public health, do you see very many people using cup feeding at home as an alternative feeding method if they can't get the baby to latch?
I'm pretty new to public health, but I honestly don't think so. I think by the time they leave the hospital, usually they have a plan in place that's a little more sustainable.
Yeah, exactly. It seems to be sort of what we're doing initially in the hospital if we can't get those babes to feed, and we have to get the sort of volumes into them for sure.
I feel like for the most part, we tend to use finger and syringe here.
Yeah.
We don't tend to use cup feeding all that often because it's messy and the milk gets lost.
Yeah, I find the same. And if you've got those measured feeds, like you've got a baby who's hypoglycemic, you're so particular about getting the exact volume in that I find it's hard to know with the cup feeding. Agreed.
Yeah. Plus you have to bundle them snugly with their hands out of the way. Otherwise they end up knocking the cup or you can't get it near. So yeah, finger and syringe tends to be the way that most people teach here.
Yeah, I agree. And I'm curious to see, like, I'm going to actually try the cup feeding again, but I find that, yeah, again, they're either jittery and they need it, or they're sleepy and they need, and we can get it in with the finger syringe. Totally. All right. Judy, have you finished eating? Do you want to try one?
Okay, let's try transport for 20.
Okay, transport for 20. So what is the document? The transfer specific document, it's a provincial document that needs to be completed by the sending site when we're sending a neonate out.
Ooh, specific document. Look at the, let's see. Like history.
Yeah, it's included in
Deliver,
that for
like
sure.
delivery or something, delivery history.
Does anybody know the document that we need to fill out?
Transport ticket?
Yeah, it's the provincial
Okay.
neonatal transfer record. So if you're transporting a baby out, you can actually pull this up on Perinatal Services BC. So if you have a little package for transport, this is really helpful. And it's got some really great information in there. Like, you know, it was designed with both rural and NICU sites.
Is there an equivalent to that in Cerner?
I don't know. It's a provincial document, so I would hope that it's in Cerner somewhere.
Probably in the form fast.
Okay.
That's interesting. I'll have to find.
Yeah, great question.
Transfer record.
Yeah, great question. Okay, good one, Judy. Rebecca, back to you. Do you want to pick one?
Sure. Let's go for transport for 30, please.
Okay. So what are we all responsible for sending along with infant transport when we're doing a neonatal transfer? So we talked about doing the BC transfer record. What else do we need to send? And Judy, this is where you had like the maternal history. So what else do we need to send along when we're transporting a baby with infant transport?
The antenatal record?
Yep. Anything else that anyone can think of?
The delivery history.
Yep.
Baby's chart.
Yep. All that stuff. So all the prenatal stuff, labor delivery record, the neonatal history, baby's chart, pertinent data. The things that are important to know are the x-rays pushed to the grid. So making sure that they have access to those x-rays. This often gets forgotten, and just check with ITT, but this is still in their document, and I appreciate it's 9 years old. But they do want a placenta in the container. They used to sort of always do sort of like an examination of the placenta as well. And of course, contact info for the parents. Okay, nice. Where we got Jennifer, do you want to pick another one?
I'm liking alternative feeding methods. Let's go with 30.
Okay. So what are the one thing that you never mentioned, the breast shield? What would be the indications for using a breast shield?
Inverted nipples, breast or nipple pain or damage, poor mouth opening by the baby, any sort of inadequate latch is a potential for a breast shield being able to be a good adjunct.
Yeah, no, great. This comes from Wolf and Glass. They're sort of like, they talk about infant nutrition. And interestingly, the one thing that they really do want us to do is to use an established milk supply, so that because the breast shields can decrease some of the sensitivity that the mom is feeling of the baby's stimulation on the nipple, that you can actually have a reduction or a lack of good milk production happening initially. Another thing that's actually another indication is transition from the bottle. Like say we've needed to use the bottle, we had a preterm, a late preterm, that was really needing measured volumes, was put on the bottle because they were sleepy, and now you're wanting to get back on the breast. And that sort of fits with breast refusal as well. And the flat and inverted nipples, when I looked about the sore nipples, because that's certainly another reason why it's commonly used, the thought was that it's hard to still get a really good latch with the breast shield because they're quite large, sometimes those breast shields, and sometimes they can still, if it's from a poor latch, it can still sort of exacerbate the sort of damage that's happening to the breast shield. That being said, I've also seen nipples heal. So great. Excellent. Okay, let's have another one. Jennifer, you looking focused? Let's get you to pick one more. Which one do you want? Oh, she's got to run. Okay, I'll head on over to Andrea. Which one do you want? What do you want to pick?
Safe sleep for 30.
Safe sleep for 30. Okay, so these are the pre-existing vulnerabilities. So Rebecca talked about one of them was gestational age, so prematurity. Does anyone else think of what other some pre-existing vulnerabilities are that make the babies more at risk for having sudden unexpected infant death?
Smoking in the household?
Yeah, so that would be sort of the exogenous factors. These are all the factors that have to do with the baby. So interestingly, a male factor, and they do look at that in context if you have a healthy term male, but they are more at risk. So genetic risk factors, they're actually just finding out that there's actually some genetic predisposition to the sudden infant death. And there's your prenatal substance. So prenatal exposure to the tobacco, illicit drugs, not necessarily what they're exposed to at the, once they're out in utero. Preterm, low birth weight, and birth of multiples. Okay. Do you want to pick another one, Andrea?
Sure. Same category for 40.
Okay, good. So the critical development period. When are babies most likely to succumb to sudden unexpected death in infancy? Does anybody know the critical time period?
The first year?
The first year, and more specifically, the peak is the 2 to 4 months. So that's good information for parents to know, like really important in those first 2 to 4 months for sure. Should we finish off safe sleep for 50? Okay. So these are the exogenous stressors. So we talked about certainly smoking in the household. Anything else that anyone think about? We talked about temperature. Jennifer got that one. Can anyone else think of anything else that would be an exogenous stressor?
Is it breastfeeding as opposed to formula?
Yeah, breastfeeding is protective. Absolutely. Yep.
Swaddling?
Yeah, swaddling, that sort of like the sharing the bed, over bundling, tobacco, soft bedding, face covering, that's your positioning. So that's why we say to all new parents, back to sleep, because then we can sort of eliminate that as a stressor, which is interesting because when we talk about the unwell babies, sometimes we are doing these things like the babies that are exposed to prenatal substance use, we're swaddling. So how do we do that safely? Upper respiratory tract infections. So if a baby gets something, particularly, in that first year, that could be definitely a risk factor. Good. Okay. Jennifer, you had to hit a call. Do you want to hit another category?
Yeah, let's do culturally safe practice.
Okay, for which one?
First one.
First one. Okay. What are the principles, and this is across the board, of trauma-informed practice? What does that mean? And there's a variety of different definitions, and I appreciate that. So I'm open to any and all. Not like there's a right or wrong.
I just had a presentation this morning.
Oh, nice.
When it's blank, I'm like, I'm easy at like ticking the correct answer, but like when it's blank, I just feel like I'm a blank.
Yeah, isn't that so true? When it's multiple choice.
Acceptance would be one of the principles. Like, I don't really know what you're looking for here.
Yeah, so when we're sort of engaging with sort of looking at trauma, one is, first of all, trauma awareness, is that all people have had some exposure to trauma, and that we always sometimes think, oh, well, do they have trauma? Do they not? We're trying to sort of, decide who we should be using this with or who we shouldn't be. And really is sort of saying, essentially, we should be using it with everybody, being trauma aware that all of us have triggers, all of us have sort of stressors or ways that we will perhaps respond in ways that are unexpected. The other one is safety and trustworthiness. So a big part of it is creating a safe space for people. What can we do to help them feel safe? And for us to support an environment that's trustworthy, that we're following through with what we say, that we don't have any surprises, that we're allowing the opportunity for choice. So much of trauma involves the lack of control, has been part of the experience. So saying to people, okay, you're going to be using, you're going to be going home with this late preterm. What are some ways that we can help support safe sleep for you at home? What do you have? How can we make this work for you? Someone's an Indigenous family and they say, oh, we historically have used the cradle boards in our family. Okay, how can we make that safe for you? And that's part of the shared decision making as well. And then strength-based. So everybody has strengths. And so how can we build on those strengths? And instead of always looking at the deficit model, like what's wrong with this person, or why can't they figure this out, instead of sort of saying these are their strengths. Does that sort of align with what you talked about a bit this morning in your presentation, Jennifer?
Yeah, it's knowing how to articulate it, because what I said was openness, like,
yep.
But like, I wouldn't have been able to come up with this.
Yeah, I like these ones just because they help me have a framework. So I'm always sort of thinking about that. What am I doing to create safety and choice and strength-based? Yep. All right. Do you want to pick another one? Should we go the second one on trauma-informed?
Sure.
Okay. So how can we support trauma-informed with families? So this is that putting the theory into action. So you've got someone who's going to be discharging home, potentially who's repatriated back, who's, like we were talking about, a baby with some risk factors for, really needing to be mindful of safer sleep, or you've got a baby who's now in the nursery. So what are some ways that we can support families with trauma-informed practice?
Connect them with resources in the community.
Yeah, excellent. Anything else?
Use non-blaming language.
Totally. We are so obsessed in our culture with shame and blame. What can we do to sort of stay curious? There's always a reason why people are behaving the way they do that makes sense to them. We just need to help them uncover what that is, or help us uncover what that is, so we can work with them. Absolutely. Anything else? Judy, do you have any thoughts on this?
Not really.
Yeah, no, it's something that we, do. And for me, the other thing too is being really mindful of the environment that we're in, that it's colonial, it's patriarchal. So what are we doing to really sort of support that space for families, that they are able to make a choice and that they don't feel like they're essentially being railroaded in? So some other tools are the brain tool, helping people be able to make informed decisions. So looking at benefits, risks, alternatives, what they're feeling about it. And if they say no, what does that mean for them? Acknowledging their strengths. Wow, you guys have a incredible, resourcefulness in how you've managed to be able to find housing. So yeah, great. Okay. Rebecca, do you want to pick another one?
Sure, I will take culture safe practices for 30, please.
Okay. So culturally safe practice. So taking a look at, in particular with Indigenous families, so, what are some ways that we can support culturally safe practice? Anybody have any ideas?
Maybe
ask them.
Oh,
Yep.
learning about their practices.
Yeah, exactly. And part of that is really acknowledging that there's a huge power gradient with us as settlers, with us as in the healthcare system, that they may not feel safe expressing that, knowing that historically that was taken away from them. They suffered tremendous abuses because of that. So, acknowledging the power gradient. Yes, this power gradient exists. How can we support you, be able to feel safe in this environment? And really, a lot of it is about us looking at ourselves as settlers. What are our assumptions? What are the things that we are assuming about this particular person? Like, not all people who are Indigenous follow traditional Indigenous practices. What else can we do to sort of, create a safe healthcare experience for them? Do we need to connect them with the Aboriginal patient navigator if there is one in your site? What can we do to, support the integration of cultural practices in our own institutions? Do we have a safe smudging if that's part of your local community? Looking at all of those things. Are you guys finding that that's starting to become incorporated more in your sites, or do you feel that there's still a long, long way to go with that? Oh, sorry, Jennifer, we can't quite hear you.
I turned it off because I was getting a report. I think we have some room to improve.
Yeah, I feel like that the more I learn about this stuff, the more I'm like, oh my gosh, I know that I'll always have microaggressions. And so what can I do and what can we do in our hospital? And you don't really realize it unless you've done that journey, just how entrenched it is. So
yeah,
I agree.
Well, and like even just when there's a presentation made, and there were things that were required that we take in terms of Indigenous cultural safety, but they blended Indigenous cultural safety with substance use as the same presentation. And I found that in itself to be insulting, because yes, there is a larger problem within the Indigenous community when it comes to substance use, but at the same time, blending it together for a teaching effort just perpetuates the stereotype.
Yeah. Oh yeah, no, that's excellent. For sure. And it's so many layers. And I think the more you learn about it, the more you start recognizing that. Yeah, that would have been really good feedback for sure for the presenters. Yeah, that's great. Okay, who would like to pick another one? Where should we go?
All right, well, I'll do respiratory distress for 40.
Okay. All right, this respiratory condition is a result of delayed absorption of fluid from the newborn's lungs. So that 90 mils of fluid on a 3-kilogram baby doesn't quite happen by the time birth happens or those first initial cries. What is that condition called? Anybody know? You see it not uncommonly. And again, for some reason, males are more at risk for this as well. Okay, it's transitory tachypnea of the newborn. And that's the classic where they can look a lot like they've got the respiratory distress. So they can look like they have the tachypnea, they're working to breathe. But the difference is their lungs sound wet versus the respiratory distress where they actually have decreased air entry. These babies are breathing through that fluid. So it can sound a bit different. Usually is self-limiting. And that's why in the new ACORN guidelines, they have the babies be up to 6 hours where we allow them that time to transition. Okay, should we do the last respiratory distress for 50? All right. What position is what is helpful to stabilize infants with respiratory distress? So this includes the TTN, transitory tachypnea, can also help support those babies with RDS. What is the positioning that is helpful?
Prone.
Prone.
Yeah.
Yes. Exactly. And it helps. And I say that with families now. I'm like, do you remember how with COVID, we were positioning all these adults prone? Well, it works for babies as well. So it allows the bases of the lungs to open. It supports the chest to decrease their work of breathing and allows containment and comfort. And hopefully, if we have a little bit of TTN, we can continue to monitor the babies and keep them skin to skin and promote that sort of physiological stability with being with mom as well. And like I say, sometimes if the babies have been in the nurseries for a while and then they go home and we're saying, oh, back to sleep, they can sort of say, but the baby loved the prone. So that can be certainly a conversation around that as well. Okay, we got a few more left, just the big numbers. Who would like to pick one?
Alternative feeding methods, please.
Okay, for 40. Finger feeding. When would we do finger feeding?
Anytime the baby can't get a latch on the breast.
Totally.
Potentially be finger feeding.
Okay. Anything else more specifically too?
I can't think of anything more specific.
Okay. So sometimes if you're doing suck training, so the babies that are tongue suckers, they just keep, you know, the ones that keep pushing the nipple out of their mouth because they just keep sucking on their tongues. So that can really help with finger feeding, is to get them to learn how to cup their tongue around the finger. If you've got a weak and effective suck, so you're really trying to get them to be able to figure out how to get a good seal. And certainly they're unable to cup or SNS and they're refusing the breast. Okay, should I do the last one for alternative feeding?
Sure.
All right. So this actually I found to be really helpful. This is the criteria for selecting an alternative feeding method when supplementation is indicated. And this comes from the Toronto protocols. And I found this one so lovely because it was so much common sense. What do you guys think? What would be part of a criteria for selecting an alternative feeding method with families?
Is it weight loss?
Yeah, oh, certainly that's an indication. Absolutely. That's why you're needing to supplement. So how are you going to know?
Like selecting the type of alternative feeding method?
Yeah, exactly.
Okay, so like if the baby's able to suck, then finger and syringe could work well. So that's a criteria if baby's able to suck. If baby's alert, that would be a criteria. Is this what we're talking about?
Yeah, and even more generally. So again, you're looking at number one, it doesn't harm the baby. It seems obvious, but really, and then like what you're talking about there, Jennifer, the nuances. What is the baby's stamina today? What is their physical condition? Are they well enough to be able to do that? What's their level of maturity? This one, the third one here for me is huge. Is it easy for the parents to manage? Sometimes I've literally gone in rooms and it's just like an explosion of like 5 different feeding methods and the parents are overwhelmed. And I've gone in there to talk to them and they're like literally throw everything out there. Like, we cannot cope with this. Another one is that the equipment's easy to clean and obtain. So sometimes the SNS might work well in the hospital. It may not be so helpful for them if they don't have water sources or able to boil things, or you know, they're not able to find a breast shield when they go home. So it's a suitable intervention for the length of time. So exactly, like finger feeding will work because we're expecting it only to be for the next couple of days. Then we're going to be looking at another plan. So what is the intervention? How long is this going to take? And it'll help the baby learn to breastfeed. So that's really sort of the other one. That's the thing about the bottle feeding. It's sometimes we see it as like, oh, we've got the baby feeding, but on the other hand, we're also telling the parents, is this going to be leading towards them breastfeeding, maybe or maybe not? Yeah. Do you guys find that one helpful at all? Or I don't know. I use that when I go with families. Okay, we got a couple more here. Should we do transport for 40? All right. So you would not believe who all the logistics that are involved with transport. Sometimes when I get super frustrated, I'm like, what's happening? So when they're figuring out the logistics, there's actually a transfer network clinical transfer nurse. And they will take a look at, first of all, the destination, the priority, the timeline. How are they going to get there? Does this baby require additional equipment for transport? What does the team need in terms of additional personnel? What in terms of equipment? Will there be ground as well as air travel? So there's quite a few logistical considerations that they have. And sometimes these are the ones I find, you guys on the coast, not so much, but out in the interior, we can wait days sometimes for transport, which is unbelievably frustrating. And it may be the fact that, you know, they're not able, their pilots have timed out. Okay. Rebecca, do you want to pick one? You're at the bottom of my screen there.
Sure, let's go for transport for 50, please.
Okay. So again, these are the 5 components. These are all the moving pieces that are part of transport. I don't know if you guys have that as much, like I say, in Sea Shelter Squamish, but certainly in the interior, if there's a holdup in any one of these pieces, it can be quite a delay. Are you guys finding that you get infants out fairly quickly in Squamish, Jennifer, or do you guys sit with them?
Sometimes there's quite a delay.
Okay.
Our best example is we had a woman arrive here after being advised by the obstetrician at St. Paul's that she could be checked here for rupture instead of driving all the way down to St. Paul's. So she showed up here, and it turned out she was 32 weeks, but with twins.
Yeah.
And when we realized that she was ruptured and what the presenting baby was breech,
Oh,
she ended up being delayed. She was still pretty closed, but she ended up being delayed almost 6 hours. And then she had like a full rupture and then a footling breach and a cord prolapse. So she went for an emergency, like a code pink stat section. And the ambulance arrived to take her away about an hour after she'd already delivered, with the intention of having taken her down with her baby still inside her.
yeah.
And in the end, the babies were born at, like, she came here at 11 a.m. Babies were born at 8:30 p.m. First baby was transported out around 11:30 p.m. and second baby went out at 2:30 a.m. and mother didn't follow them until almost 11 the following morning.
Oh, wow.
So it did not go smoothly. And we do have some significant delays, including doing CPAP for several hours, awaiting infant transport, because they won't go wheels up unless the baby's already been born and is alive.
Oh, I know. So
So we get some significant delays.
all right.
And then we also get miscommunications in the like the baby has arrived, but it's under 2,000 grams, so it's not allowed to stay here. And the ambulance arrives, but they have no safe way to transport the baby.
Oh, no.
So they won't put the baby on the mom's chest and take in a stretcher. So they say, oh, we're going to get a car bed from Richmond, and then we're going to come and bring that, and then the baby's going to leave that way. But then 5 hours later, when the ambulance actually arrives again, they don't have a car bed. They know nothing about the plan, and they end up taking the baby on the mom's chest on a stretcher.
Okay.
So we've reported these in a few SLSs in the past and reported them to our manager. Or if a mom's going urgently because she's still pregnant and needs to leave hospital, they've interpreted it as lights and sirens, and the father has been left in the ambulance bay because they've refused to take him along because it's too high a risk for the father to be in the ambulance with her, and they have no transportation and they don't own a car.
Oh my gosh. Wow. Yes, you certainly have touched on a lot.
A lot of the problems. Yes.
Yes. Yes. And then when I took a look at all the components, it's interesting when you look at Alberta, they have a much more streamlined process, but we have, first of all, the sending practitioner, we've got the call facilitator, then we've got the transport coordinating physician, then we've got the logistics team and the receiving physician. There are a lot of moving pieces, and I think this is where it gets lost in translation. You might be talking to one person, but you know, the transport coordinating physician, I know nurses who work there said that they would say something and the nurse would be like, you know where you're talking to? Like, do you know where they are? Like, do you know what they have? And they actually don't. And
we actually have an example of that here right now. She's 35 and 4. We're supposed to be a 36 plus hospital. She was 3 centimeters. The neonatologist has told us that a 35 and 4 is not really much different than a 36, and she'll be fine to deliver here. We have no NICU, we have no pediatrician. So, but she's delivering here.
Yeah, and I hear you. And we wound up with the same problem with very unwell babies at 35 weeks and days to transport out because of snow. So I know it's super frustrating, and I know that these are being forwarded by health authorities as well. Certainly some concerns, so I empathize. I wish we had some way to fix these problems, but oh my goodness, it does not seem to be an easy way.
We have parameters, we just can't follow them.
Yeah, exactly. Okay, so here is trauma informed. So what do we do when this poor partner's left in the ambulance bay? What do we do when we have families that are waiting and stressed, and they can see we're stressed and there's no transport, or the mom who can't go with her babies for 24, 12 hours? Yeah.
Well,
What do
we
you
try to
do?
inform them as best we can.
Mm-hmm.
We use all of our empathy. We provide resources. We provide information on how to give feedback if the system isn't working.
Mm-hmm. 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 Yeah. Anybody else have any ideas or suggestions?
Hi, I joined a couple of minutes late. I'm Anne-Marie. I'm a midwife on Haida Gwaii.
Hello.
Hot cup of tea.
Yeah.
Hot cup of tea to everybody all the time. Works like a charm.
Yeah. So those comfort, sort of acknowledging that humanity in them, and they're not just another number, for sure. Some kindness. Yeah. Resources, supports. It's not an easy answer, and I have no answer for this, just because, you know, it is nuanced. It depends on what's happening in that site. I think human connection is huge. I've been lately on the other end of the healthcare system with family, and I can tell you that human connection goes a long ways. All right, I got one more, last one, culturally safe practice with Indigenous families. Hot cup of tea will also work beautifully. Anything else that we can do in particular for Indigenous families?
Ask permission for any interventions. Sit down next to them when you're talking to them. Introduce yourself. Ask what it is they need from you.
Yeah. Excellent. Anything else anyone can think of?
Connect them with the Indigenous navigator.
Yep. Yep, for sure. Make sure that they have advocates that can speak for them, someone that they feel safe with. Anything else? Yeah, and I think just allowing them that opportunity to, you know that they can speak and you know, support what it is that they are needing to, you know, feel supported. Do they need an elder? Are they able to access that? Many of our Indigenous families are coming away from more rural, remote communities. So they may be alone, they may be staying in a hotel, they may not have transport. So certainly recognizing and acknowledging all of those barriers that have been created because of colonization. Excellent.
Friendship centers have often been good referrals in bigger cities for us.
That's a great tip. Yes, and I forget about that one often. So that's a great tip. Perfect. And then when people are looking from that side, they may also have additional resources and tips that we may not know, being sort of remote or rural or, you know, settlers. Great. All right. Well, thank you guys. I do have, if anyone needs, I've got the sort of list of resources if anyone's interested at all. But I'm just curious, any takeaways from today's little session? Any sort of comments or thoughts? Transport is certainly giving us all gray hair. I already have gray hair, so I'm hoping it'll start reversing gray. Any other thoughts or comments? I appreciate all that you guys do in rural sites. Boy, it's definitely a challenge, and it's, you know, very much appreciated. Anne-Marie, is there anything you'd like to say? I'm sure you have lots of challenges from the Haida Gwaii in terms of transport.
I was going to say it was nice to hear other people moaning about transport. Sometimes I feel like we have it so bad, and it's like nice to remember that we're not alone. And, you know, when I was looking at some national data around transport, it was really interesting to see that, like, BC, just our geography and the distance between places is just so hard. And a lot of the other provinces, like, they have like 2 helicopters for the whole province. And we, you know, I have a lot of compassion, and I appreciated your angle on just like really appreciating how hard how many moving pieces there are with transport.
Yeah, for sure. And it is interesting. ITT is the only transport team that I know of in the world, and they even say that will actually transport unwell neonates, pregnant moms, and high-risk moms. So it is a pretty unique skill set that our team has for sure.
We love them.
Mhm.
We love them so
Yeah,
much.
we have to wait way too long for them sometimes. We need more of them.
There was a news announcement the other day about a group in Parksville with like 4 helicopters or something that was recently hired by BC EHS. So maybe there will be, maybe it'll improve.
Stay tuned. Stay tuned. Yes. All right. Thank you, everybody. Great to have you guys on today.
Thank you very much.
Thank
Take
you.
care.